live now, ma.
Okay. Good evening, everybody. It's my pleasure to start this GIFT program. Sorry for this IFS South Tamilnadu May program webinar on 24/5/24. And for this monthly CME, we have a very important topic of poor ovarian reserve. So for this, we have two important speakers, Dr. Lena Vadva and Dr. Naushin. Dr. Lena Vadva is going to talk about poor ovarian reserve, how to classify and stimulate. And Dr. Naushin, she's going to talk about ovarian reserve, can it be improved? Because nowadays we very often see reduced ovarian reserve even in young girls. And they finally land up with infertility problems. And it is our duty, at least through ART, we have to give them a baby. So for this, we have so many methods or so many things to modulate so that we get at least few eggs and good embryos out after stimulation. So on behalf of South Tamilnadu IFS, I welcome both the speakers as well as the delegates for today's webinar. Sagiti, next you can play the prayer song.
கருவாக்கி உருவாக்கி எனையாண்டு காத்தருளும் இறைவா நன்றி. எங்கும் நிறைந்தோனே எல்லை இலாதானே, எங்கேயும் எப்போதும் என் குலம் காப்பவனே. நெஞ்சம் துணிய துணையாய் வருவாய், நேர்மறை உணர்வுகள் பெருகிடச் செய்வாய். உடலில் உறுதியை பெரிதாய் தருவாய், உனை உணரும் அறிவை என்னுள்ளருள்வாய். சுற்றமனைத்தும் காப்பவனே, செய்தொழிலில் ஏற்றம் தருபவனே, எடுத்த செயலில் வெற்றி கொடு, என் ஆற்றல் பெருகிட அருளை கொடு.
Next, Dr. Victoria, you can present the Secretary's report of the last month program.
Thank you, Madam. Good evening, everybody. At the outset, I'd like to welcome you all for this monthly webinar. I am Dr. Victoria Johnston, Assistant Secretary for the IFS South Tamilnadu chapter. In the absence of Dr. Chitra, I'll be helping Ramani Madam to coordinate this meeting. The last meeting was on 23rd April 2024. It was a part of the Endo Talk, that is the Exploring the Enigmatic Disease Endometriosis webinar series 3. It was a webinar with the theme Diagnosis of Endometriosis. It was a joint meeting of the IFS Pondicherry chapter and the IFS South Tamilnadu chapter. There were talks on imaging, inflammatory markers, etc. The imaging in endometriosis was done by Dr. Sunita, and the talk on novel markers and endometriosis was done by Dr. Ramani Devi, the patron. And there was an interesting article presentation by Dr. Tendril. It was a very successful webinar and almost 176 delegates, because it was a joint meeting. We had about 176 delegates attending this webinar, and they were all very much benefited, and there were a lot of interaction from the delegates. So now we move on to this webinar for today. This is our monthly webinar for the month of May. The first talk is by Dr. Lena Vadva. She's going to talk on the poor ovarian reserve and how to classify and stimulate this kind of patients. We very often find that the success of ART depends on the ability to get a number of good quality oocytes. And this becomes a problem in a group of patients. We need to know how to classify these patients and how to stimulate them. So we have Dr. Leena to talk to us and enlighten us about this topic and clarify all our doubts. Dr. Leena is the professor and HOD of the ESIC Medical College, Alwar. She's a senior IVF consultant. She is credited with setting up the first IVF center of the ESIC. She is a treasurer and co-convener of PCOS Society and the IFS. She has fellowships from the Foxy Ethicon, Foxy Dr. Vasant Ben Shaw Overseas Scholarship, and the Reproductive Medicine and Endoscopy Fellowship from Germany, Kiel. She has performed the Dr. Kamini Rao Foxy Oration on Maternal Mortality at the AICOG. She has edited books on the current concepts in contraception and women's health. She has 50 research topics, paper publications to her credit. She has received the IFS Achiever Award in 2022 for her contribution in the field of infertility. Over to you, madam. This is a very interesting and very important topic for all ART specialists and infertility specialists who are going to be listening to you wholeheartedly. I hope at the end of the talk, we'll have a number of doubts and many myths clarified. Thank you, madam.
Yeah, thank you, Dr. Victoria, for the kind introduction. Am I audible?
Yes, madam.
Yes, you are audible. Make it full. Good.
Yeah. So today we have a very important and challenging topic on poor ovarian reserve, how to classify and stimulate. So it is very important for us to know that the incidence of poor ovarian response is high. It ranges from 9 to 24% in women undergoing ovarian stimulation for ART. And the poor ovarian response, the poor responders, it includes a heterogeneous group. It includes both expected as well as unexpected poor responders. And we know that the pregnancy is dismal in this group, ranging from 7.6 to 17.5%, whereas it is 25.9 to 36.7% in normal responders. So it is a challenge for the clinicians to handle poor responders. Until now, before 2011, there was no consensus definition for poor response. And then came the Bologna criteria in 2011, in which poor response was defined by at least two of the following. Number one, advanced maternal age more than 40 years or any other risk factor for POR. Number two, a previous poor ovarian response, that is less than 3 oocytes retrieved with a conventional stimulation protocol, or an abnormal ovarian response was defined as antral follicle count ranging from 5 to 7 or AMH ranging from 1.1 or 2 episodes of POR after maximal stimulation, that is less than 4 oocytes retrieved. But there were certain shortcomings with the Bologna criteria. The definitions were not very clear. There was no exactly discrimination between decreased ovarian reserve from low or suboptimal ovarian response. And there was the population, there was heterogeneity. All the population, all the different age groups, they were included in a single box. Basically, this criteria did not provide recommendation for clinical decision-making, counseling, or how to manage POR cases. So then came the Poseidon criteria. The Poseidon classification is basically patient-oriented strategies encompassing individualized oocyte number. Now, this classification includes 4 subgroups based on quantitative and qualitative parameters. That is age and the expected aneuploidy rate. It takes into consideration ovarian biomarkers, that is antral follicle count and AMH, and the ovarian response if previous stimulation cycle was performed. So this definition helps clinicians counsel and set patient expectation and helps in establishing a working plan to reduce time to pregnancy. So let us try to understand this classification. This is a very, very important classification, which is now being used for patient management. The Poseidon 1 and 2, they are the unexpected poor ovarian response. The one includes the young patients less than 35 years. They have adequate ovarian parameters, that is, antral follicle count is more than 5, AMH is more than 1.2, with an unexpected poor or suboptimal ovarian response, that is, the number of oocytes retrieved. It is subgroup 1A if it is less than 4, and 1B if 4 to 9 oocytes are retrieved after standard ovarian stimulation. Whereas the Poseidon group 2 includes the older patients who have a good ovarian reserve with an unexpected poor or suboptimal ovarian response. Coming to Poseidon group 3, we need to remember that 1 and 3 are the young poor responders. The group 3 and 4 are expected ones. In group 3, these are young patients, but their reserves are less. AFC is less than 5, AMH is less than 1.2. And in the Poseidon group 4, these are the older patients, more than 35, with a poor ovarian reserve. Let us try to understand this by different examples. So this patient, she is a young patient, 28-year-old, married for 2 years. Look at her antral follicle count. It is good, 4 to 5, 3 to 4 on other side. Her hormonal profile is okay. Her AMH is okay. She underwent IVF with short agonist protocol, but only 3 oocytes were retrieved, out of which 2 fertilized, a fresh embryo transfer done, and she failed to conceive. So now this patient falls into Poseidon group 1. That is the young patient with an unexpected poor response. Her ovarian reserves, if you look at the reserves, they are very good, but the number of oocytes retrieved were less. Now, look at this case. She is 38-year-old patient, means she's an older patient, but her ovarian reserves are good. And on undergoing IVF agonist protocol, only 3 oocytes were retrieved. 2 fertilized, fresh embryo transfer done, failed to conceive. So this patient, she is an older patient with an unexpected poor response. So she falls in Poseidon group 2. So 1 and 2 are both unexpected poor response. Now coming to next case, she is a young patient, 30-year-old, but look at her ovarian reserves, they are very less. Antral follicle count is only 1 or 2. The hormonal profile, FSH is high, AMH is very low. She underwent antagonist cycle, 2 oocytes retrieved, ICSI done, 2 embryos formed, fresh ET done, failed. So this patient, she is a young expected poor ovarian responder belonging to Poseidon group 3. And similar case, she's 38 years and her ovarian reserves are on the lower side. 1 or 2 antral follicle count, AMH 0.6, underwent ANTAC protocol, 2 oocytes retrieved and fertilized, fresh ET, failed to conceive. This patient, since beginning, she is older patients with poor ovarian reserve. So she's an expected poor responder. Old expected poor response falls into Poseidon group 4. So after this basic understanding of the Poseidon classification, now let us understand how to stimulate these poor responder patients, which protocol we should use. The common protocols which we use are the GnRH agonist protocol, which includes long protocol, short and ultra short. We don't use ultra short protocols, long protocol and short. Short is also known as microdose flare-up protocols. So these are the protocols which are used. And another one is antagonist protocol. Now let us try to understand the difference between these protocols and which one is better for which group of subgroup of poor responders. So in this, I'll quickly go through this slide. This shows the different types of protocols. Just to summarize, an antagonist protocol, we start on day 2, day 3 with gonadotrophins, add antagonist, if it is a flexible at the follicle size of 14 millimeter or day 6 fixed protocol. Then we have the long agonist protocol, in which we start agonist from mid-luteal phase, 0.1 milligram. Then on day 2, after desensitization, start with gonadotropin, reduce the dose of GnRH agonist, then give HCG trigger and then do the ovum pickup. And in short agonist or microdose flare-up protocol, the GnRH agonist is started from day 2 in a dose of 0.1 milligram and is continued till the day of trigger. And we add gonadotropins after 2 days. If you look, the dose of gonadotropins, which I'll be further discussing in detail in all these protocols given, was 300 IU. And we'll be discussing subsequent with mild stimulation in further future slides. Now, looking at the difference between these protocols, the pros and cons, the long GnRH agonist protocol, it has good luteal FSH suppression, better follicular synchronization. But the drawback with this protocol is it causes excessive suppression in POR group, more dose, longer duration. Short GnRH agonist, it causes early follicular FSH suppression. The initial flare effect of GnRH agonist is utilized, but the drawback is ineffective suppression due to raised progesterone in early follicular phase, which may be detrimental. And then we have the antagonist protocol. It causes late follicular FSH suppression, lesser injection, less dose, less duration of stimulation, patient-friendly, but the cost may be a factor, and short half-life, so strict timing of injection is important. So there have been studies comparing these regimes, GnRH antagonist versus GnRH agonist protocol in poor ovarian responders undergoing IVF. Then there was a very nice study by Shesh Kamal Sankara in which long GnRH agonist protocol was compared with short agonist, and it was found that in expected poor ovarian response, the long GnRH agonist protocol non-significantly increased mature oocyte by 1 oocyte compared with entire. So it was thought that the more the better. Even if you're getting 1 extra oocyte, it is better. But overall, it was seen there was no increase in clinical pregnancy rate or live birth rate. Although in Sankara study, they didn't study the live birth rate and the clinical pregnancy rate. So in the further systematic analysis done by Lembach, they also found no evidence of difference in ongoing pregnancy rate overall between the antagonist and the agonist group. But on doing further subgroup analysis, that is what the ASHRAE also recommends, that overall there's no difference between antagonist and agonist protocol. But now the studies which are coming up, they are classifying patients as per the Poseidon criteria and studying the different protocols as per the Poseidon group. So this is a Chinese study. This is a retrospective study of 1,233 patients with diminished ovarian reserve. And the patients were divided into 2 groups based on age. One was the younger Poseidon group, and the other was the older patients of Poseidon group 4, age more than 35 years. And in this study, it has been pointed out that in the younger group, it was observed that GnRH agonist protocol showed a lower embryo transfer cancellation rate and a higher live birth rate compared to the entire protocol. So this study concluded that GnRH agonist protocol was more effective for young patients with DOR, suggesting a potential relationship with embryo quality or endometrial receptivity, although more such studies are required. Then this was another study in which the efficacies of different ovarian hyperstimulation protocols in poor ovarian responders classified by Poseidon criteria were studied. In this, they further classified the GnRH agonist long protocol into 2 groups. In one group, they gave long depot preparation of long-acting GnRH agonist in early follicular phase. In the second group, GnRH agonist was started as usual in the mid-luteal phase, and in the third group, ANTAC protocol was used. In this study, it was demonstrated that GnRH agonist, long-acting, used in the early follicular phase, had higher pregnancy and live birth rate in the young poor responders. So this also needs further trials. Coming to the gonadotropin dose, what should be the starting dose in poor responders, whether we should start with a very high dose or we should go for a milder stimulation. That's another point of contention. We know that in poor ovarian reserve, the recruitable follicles are very less, especially in the expected poor ovarian responders. So the gonadotropins, independently of the dosage administered, can only support the cohort of follicles receptive to stimulation without manufacturing the follicles de novo. So the increase of FSH starting dose does not result in higher pregnancy rate. And it was observed that there was no difference between the starting dose of whether you start with 300 or 450 or 600 in terms of retrieved oocytes, number of embryos, and pregnancy rates. So the current evidence supports a maximum daily dose of 300 IU of recombinant FSH in the expected POR patients, as higher dose neither increase the clinical pregnancy rate nor the live birth rate. Coming to the mild or minimal dose protocol. So this mild dose protocol, it includes lower dose of gonadotropins along with clomiphene citrate and or letrozole. So there was a very nice meta-analysis published in 2017 in which it was observed that combination of clomiphene and gonadotropins in an ANTAC protocol was not superior to gonadotropin in a GnRH agonist protocol in terms of live birth rate. So I'll just sum it up that addition of letrozole with FSH in a ANTAC versus conventional ovarian stimulation, there was no difference. And ESHRE 2019 does not recommend the addition of letrozole to gonadotropins in stimulation protocols for predicted poor responders. But however, clomiphene citrate alone or in combination with gonadotropins and gonadotropin stimulation alone have been equally recommended. So clomiphene with gonadotropins or gonadotropins alone has been recommended in expected poor responder patients. And what does mild stimulation with gonadotropin alone means? You're giving FSH dose of less than 150 IU per day compared to conventional FSH stimulation. So the ASRM 2007 guidelines recommend strong consideration to a mild stimulation protocols. Low dose gonadotropins without oral agents due to lower cost and comparable low pregnancy rates in poor responder patients. So this was a very nice systematic review and meta-analysis published by Kumar Datta in Reproductive Biomedicine in 2020, in which mild versus conventional ovarian stimulation for IVF in poor responder, a systematic review and meta-analysis was done. And they didn't find any difference in live birth rate or ongoing pregnancy rate between conventional and mild stimulation IVF, although the cycle cancellation per started cycle was little higher with the mild stimulation IVF. So coming next to what is the role of adding LH? Should we add LH with the gonadotropins in this group of patients? So we know that patients with advanced age, 36 to 39 years, history of follicular stagnation, or if there has been history of increased dose requirement more than 3000 IU in previous cycle, these are the candidates who require addition of LH. Consider adding recombinant LH, then increasing the dose of FSH, and the ratio should be 2:1 from day 1 of stimulation. And it has been mentioned if there is hypo-response to gonadotropin, these are the patients, they benefit from LH supplementation. So now once you know the protocols, you know the gonadotropin dose regarding the addition of LH, especially the patient is elderly, expected poor responder. Then next comes the role of trigger. So there's been a lot of debate about the dual trigger, effect of dual trigger on reproductive outcome in low responders. This has been a systematic PRISMA and meta-analysis published in 2021. This meta-analysis indicated that dual trigger as final oocyte maturation is advantageous in low responder patients compared to SCG trigger among poor ovarian response. But recently, there has been study which has been published in 2024 in which cycle outcomes of dual trigger, GnRH agonist plus SCG versus SCG alone in Poseidon group 3-4 poor responders and normal responders were compared. This was a prospective randomized study, although it included only 225 women. And in this RCT, they found that live birth rate per embryo transfer was significantly higher in the SCG group versus the dual trigger group in expected poor response women. So this is still debatable and it needs more of studies. Now let us have a look. What are the newer protocols coming in for poor responder patients? Duostim versus biostim. In duostim, you're stimulating in the same cycle, follicular as well as luteal phase. And in biostim, it is the consecutive cycle. Then what about the PPUS protocol, which is now coming up in a big way? And what about the stop protocol? So dual stimulation in this group of patients, since aneuploidy rates, we know they are higher in this group, especially the older group compared to women less than 35 years. Higher oocyte yield is needed to achieve a single euploid embryo. So double stimulation strategies can help in maximizing oocyte yield in a single ovarian cycle. So that was the concept for duostim, and we know that it is based on the wave theory, that there is continuous recruitment of follicles happening, which is utilized. So I'll not go much into details. But important points in duostim is when you're stimulating, the first trigger is always a GnRH agonist trigger, so as to bring early luteolysis and a more suitable internal hormonal milieu to start the second ovarian stimulation. The second ovarian stimulation is started after 3 to 5 days of first ovum pickup so that there is adequate fall in estrogen level. And this would shorten the duration of controlled ovarian stimulation in the luteal phase, reducing duration of gonadotropins. Patients will normally experience menstruation during second phase of COS, which shouldn't make us stop the cycle. The controlled ovarian stimulation should continue. The second trigger can be SCG or GnRH agonist. And it is very important in duostim, all embryo transfers are cryopreserved and they are cooled and they can be subjected to PGS or non-PGS if required. So there has been various studies and this Shanghai protocol, this is very quite famous, in which double stimulation during the follicular and luteal phase of poor responders was done. This is a Chinese study in which the letrozole was given for the initial day 3 to day 6, followed by gonadotropins, followed by GnRH agonist trigger. And in this medroxyprogesterone acetate 10 milligram was used. And once the oocyte retrieval was done, then the second cycle was started with HMG 225. In this, the medroxyprogesterone was added only in the later part and followed by GnRH agonist trigger and oocyte retrieval. So this protocol has been found to be viable and potential option for poor ovarian response and then also for oncofertility preservation. So I've explained the Shanghai protocol, mild ovarian stimulation with letrozole and clomiphene and low dose HMG. After the first pickup, again HMG and letrozole, and then second opioid done. And this is a BISTIM study, famous BISTIM study, randomized control trial comparing dual ovarian stimulation, that is duostim, with 2 conventional ovarian stimulation in poor ovarian responders undergoing IVF. So they compared duostim with 2 consecutive ovarian stimulation. And this study found that there was no difference in mean cumulative number of oocytes retrieved between the control and duostim group. While the implantation rate was similar, cumulative live birth rate showed no statistical difference, indicating that duostim did not confer additional benefit over 2 consecutive antagonist cycles. Actually, there has been debate that in duostim you have to go for freeze-all. Whereas if you are going for double stimulation, you have a chance for fresh embryo transfer, because there are chances you may retrieve less of oocytes and you might need to go for fresh embryo transfer. So this is debatable. And this was a SWOT analysis done of double stimulation, which I was discussing. The strength is you get increased number of oocytes and embryos retrieved. So you get more of embryos for pooling. And the studies have found there is no difference in competence between oocytes obtained after follicular phase stimulation and luteal phase stimulation. The weakness is more stimulation cancelled in luteal phase. There are no RCTs or cost-effective analysis. Then freeze-all approach is mandatory, which is another cost factor. And this can be applied only to poor prognosis patients. So coming to next part about the luteal phase stimulation. Is it the same as the follicular phase stimulation when we are in duostim? So luteal phase after conventional stimulation in same ovarian cycle might improve the management of poor responder patients fulfilling the Bologna criteria. This has been case series which has been published. And the conclusion was that the luteal phase derived oocytes, they was found to have increased clinical live birth rate per intention to treat in a single ovarian cycle in patients fulfilling the Bologna criteria, and duostim appears to be promising, and definitely it avoids the dropout rates. So this is another study in which what is the true place of double stimulation and double oocyte retrieval in same cycle for patients diagnosed with poor ovarian reserve. This was a systematic review and meta-analysis. And then another study, they all have pointed out that luteal phase is not correlated with higher aneuploidy rate. It is promising for time-sensitive nature of poor ovarian reserve patients. So luteal phase stimulation, it needs further trials, and because there are not much studies to finally comment regarding the luteal phase stimulation. And another study published in 2021, it mentions that luteal phase stimulation requires longer duration and higher dosages of gonadotropins. A word about the short agonist stop protocol. This is a newer protocol which is coming up. In this, the GnRH agonist flare-up is utilized in the initial part, followed by gonadotropins, and then the antag is added later on. So this is a new protocol being tried in poor responder patients. And then coming to progesterone primed ovarian stimulation. So this is a meta-analysis which has studied the efficacy of PPOS using medroxyprogesterone acetate in ovulation induction in poor ovarian responders. So I'll not go much into detail, but this meta-analysis has pointed out that PPOS, if used in poor ovarian responder cases, can reduce the need for cycle cancellation, improves the follicles and embryos, improves the pregnancy rate, and thus it can present an effective choice for IVF ICSI-ET in patients with poor ovarian reserve. And what is the advantage of PPOS in poor responder? That medroxyprogesterone, when it is used in 10 milligram per day in the early follicular phase, the studies have suggested that the metabolites of medroxyprogesterone acetate includes androgens, which helps to promote the proliferation of granulosa cells in patients with poor ovarian response. and also stimulates the growth and development of follicles and thus improves the quality of eggs or embryos. So PPOS is now coming up for poor responder cases, but the drawback is you have to go for freeze-all strategy with PPOS. So to conclude, poor responders remain a challenge to clinicians and embryologists. Poseidon classification gives us better understanding than Bologna criteria. There's no individual pituitary separation regime is superior over the other. GnRH antagonist results in lesser stimulation days. Dual stimulation may be advantageous, although this is debatable. PPOS and mild stimulation, they appear promising. Understanding young POR is an area of research, and counseling is an integral part for poor responders. Thank you.
Thank you, Dr. Reena. It was a very clear-cut, precise talk about a very difficult topic of this poor ovarian reserve. You have made it very simple.
Thank you, ma'am.
What I should say. I think it's you have made it crystal clear. Dr. Victoria?
PPOS, what are the drugs which you have used, madam, so far? Have you tried with the difestone also, dydrogesterone also?
No, madam, actually, we have not used PPOS in poor responder cases.
Okay, madam.
I think now we should start using it. And medroxyprogesterone acetate, when I was going through the literature, it is more useful as because of the androgens which is secreted as a metabolite of MPA, and it helps in follicular growth. We
have tried PPAS. Okay, the results were okay.
Okay.
For patients with
for patients or for donors, madam? Did you use it for donors or did you use
for donors? Because we have the donors, they get stimulated only for our own
patients. You have tried.
I have tried mild stimulation protocol for poor responder cases. I am a proponent of mild stimulation, and especially those with expected poor responders. You get good quality of oocytes and good outcome.
And dual stimulation, madam? Have you done dual stimulation frequently in your cycles, in your ART cycles?
Not frequently, not frequently. Actually, that also I'm not in much favor. I prefer subsequent stimulation because you get the opportunity for fresh embryo transfer in these group of cases.
And oocyte pooling, have you done for anybody? Oocyte pooling?
Usually we prefer fresh embryo transfer.
Fresh, okay. Thank you, madam. That was a very nice presentation. You have cleared many of our doubts. Shall we move on to the next topic, madam? Ramani, madam?
Victoria, you can invite the second speaker and introduce.
So at the end of that presentation on how to classify and stimulate poor ovarian response, we have this question asked by all our patients. Why is it for me alone like this? Can there be anything done to improve my ovarian reserve? So we come to this very important topic on how to improve the ovarian reserve, and if at all possible, can it be really improved? And if it is possible, how it can be improved? And the talk is going to be given by Dr. Naushin. She's the director and senior consultant in reproductive medicine from the Kraft Hospitals and Research Center across South India, Maldives, and Middle Eastern Asian countries. She's an FNB and FRM teacher. She's a recipient of several awards like the Young Turk Award from Foxy 2020, the Pearls of Talks Award, the Manish Bankar Young Achiever Award, the ISAR Youth Icon Award, and the Gautam Kastagir Best Researcher Award. She's a member of the Indian Editorial Advisor Board of the ACOG. Welcome you, Dr. Naushin, to elaborate on this very interesting topic.
Thank you so much, Victoria ma'am, for the kind introduction. First, I would like to thank Chitra ma'am for inviting me. It was lovely meeting her during the last ISA. Similarly, I'm happy to share space with Remni ma'am and Leena ma'am. Shall I start the screen sharing?
Yes, yes.
Is my screen visible now?
Yeah, it's visible. You can go ahead now, Shane.
Right. I can't switch on the video now. Not sure where the... Okay, I'll start the presentation anyway.
Yeah.
Sorry, 1 second. Yeah. So the question is, can poor ovarian reserve... 1 second. Yeah. So the question is, can poor ovarian reserve be improved? The screen is not moving.
You just click it over the screen and then move.
Yeah. Okay. Is it moving now?
Yeah.
Right. Okay. So we will look into the common adjuvants used to improve functional ovarian reserve. The major categories are androgens like DHEA, transdermal testosterone, antioxidants like coenzyme Q, and growth factors like growth hormone, PRP, and stem cell. I'm going to discuss only the well-researched ones, keeping aside a gazillion adjuvants. Apart from these, there are other emerging concepts like in vitro activation and mitochondrial boosting, which I'll be discussing later. So first, coming to androgen supplementation. In the ovary, androgen receptors are detected in several stages of follicular development, right from the primary stage onwards. Androgens play a key role in the primordial follicular growth. Animal studies have shown that testosterone promotes primordial follicle to primary follicle transition via androgen receptor mediated pathway directly rather than by transformation into estradiol. Androgen receptor signaling is necessary for progression beyond the preandral stage to andral stage. When andral signaling is blocked, preandral follicles cannot progress to andral follicles and they undergo atresia. Even the genetic studies have confirmed the role of androgen-mediated activity in the oocyte development, and those with inactivated androgen receptors have reduced fertility, defective follicular genesis, and atresia. So from the transition of primordial follicles to primary follicles, androgens plays a key role in the growth of the primordial follicle, and they increase the IGF-1 receptors and IGF-1. While from the transition from primary follicle to preandral and andral follicle, androgens play a role in increasing the granulosa cell proliferation, increases the IGF-1 and IGF-1 receptors, increases the FSH receptors, sensitivity to FSH, and they also stimulate anti-apoptotic pathways. Now, in the periovulatory follicles, the role of androgens in this periovulatory stage is controversial, with the animal studies showing contradictory effect. However, one school of thought says that it increases the response to FSH, increases the oocyte maturation, ovulation rate, and number of corpus luteum, while the others suggest elevated androgens negatively affect the mitotic resumption. So now coming to the first adjuvant. Again, the screen is stuck. Okay. Yeah. There is plethora of articles on DHEA. Majority of the studies published were not based on Bologna or Poseidon criteria, adding a lot of heterogeneity. And it is important to note that no pharmacological studies have been performed to determine the optimal dose, duration, or time of DHEA supplementation in POR patients. So because of which, ESHRE 2023 does not recommend DHEA for POR patients. However, there is growing evidence supporting the use of DHEA in POR. This is one of the largest meta-analysis called as network meta-analysis. It's quite a renowned one, assessing around 19 RCT, strictly applying to Bologna criteria, comparing different adjuvants to each other. And it showed that DHEA and coenzyme Q clinically improve the pregnancy rate. Subsequently, this is another network meta-analysis published last year, again restricting to Bologna criteria, showing benefit with DHEA. Similarly, Cochrane also supports DHEA use in POR with moderate quality evidence. Now, this is an RCT, though small with absence of sample size calculation, Still, it is one of the most cited one, mainly because this is the first RCT assessing the role of DHEA in specific posidone group, that is posidone group 2. And they show that the DHEA increase the live birth rate. Probably because of all this, DHEA was included in the POR management chart introduced by Peter Humedin, who suggests DHEA in posidone 2, 3, and 4. However, after nearly 20 to 25 years of use of DHEA, which was introduced by Barad and Gleischer, they had put up a caution news infertility sterility, warning doctors about significant increase in the androgen levels in patients taking 75 milligram of DHEA after 1 month. The authors recommend starting with a lower dose of 25 milligram TDS and adjusting the androgen dose depending upon the levels after 2 to 4 weeks. They suggest that it is beneficial only for hypoandrogenic women undergoing IVF, and excessive testosterone can have adverse effect on the ovaries and follicular development. According to them, the ideal dose could be for about 6 to 8 weeks. The reason why they were suggesting for this was that after 2020, because of the COVID, there was a change in the biological potency of the Chinese raw material used in the DHEA supplements, which could have led to increased testosterone. However, I don't agree to that comment that it is post-COVID APC change. Our MD, Dr. Ashraf, 20 years back itself used to start DHEA only in hyperandrogenic cases, and we used to see plenty of patients with testosterone levels going above the reference range with just 1 month of supplementation. So this elevation of testosterone was always there. Probably they started noticing or evaluating it in recently. Maybe some of the delegates or the faculty can also comment later about their experience on DHEA. So my conclusion on DHEA, considering the background fact that each oocyte adds to a pregnancy rate of 5%, with the limited evidence, since DHEA is not as expensive or invasive like growth hormone, we can supplement for posidone 2, 3, and 4 if they are found to be hypoandrogenic. While for posidone 1, strategy would be intense stimulation and synchronizing the cohort. However, once the supplementation is started, we need to monitor the testosterone values to prevent adverse effects. Now coming to the next molecule, which is testosterone. It is the testosterone and dihydrotestosterone which bind directly to the androgen receptors, while DHEA act as a substrate for the conversion into testosterone and dihydrotestosterone. Hence came the concept of directly supplementing with testosterone rather than DHEA. First, coming to one of the important testosterone trials in Bologna POR patients, which is called as a TestoTrim trial, which involved either supplementing 12.5 milligram of testosterone for 2 months versus 12.5 milligram for 10 days versus nothing. And the study results show that there is no difference in the outcome measures. Similarly, even the much discussed first multicentric trial, the T-Transport trial, where transdermal testosterone of 5.5 milligram was applied for 2 months, followed by stopping and then starting the stimulation versus placebo. Although the results are not published yet, the author, that is the Polizos, presented the data at the last ESHRE in Denmark, which showed no difference in any of the outcome measures. Similarly, even the network analysis showed there is no benefit with the use of testosterone, and even ESHRE again does not recommend it. So my conclusion is that again, it's not recommended. On top of that, the side effects with testosterone gel, like the acne, alopecia, deepening of the voice is higher when compared to that of DHEA. Now coming to the next molecule, that is coenzyme Q10. Coenzyme Q10 is a lipid-soluble coenzyme. It's an essential component of inner mitochondrial membrane, and it helps in the transport of electron to produce ATP in the mitochondria. Coenzyme Q10 reduces the mitochondrial oxidative stress, improving the oocyte competence, and it is shown that the levels of coenzyme Q10 decreases after the age of 30 in contribution to the ovarian aging. Though ESHRE does not recommend the use of antioxidants, this one molecule coenzyme Q is one of the widely studied and used molecule in different departments of medicine, right from neurology to cardiology to dermatology and reproductive medicine. like PRP and stem cell, it is considered as an anti-aging medicine. But there are no much RCTs on this aspect in Bologna or Procedure. This is a single RCT published in 2018 evaluating the role of coenzyme Q10 in Poseidon 3 group, which showed improvement in the number of oocytes and the embryos. However, there was no change in the pregnancy rate or live birth rate. As I was mentioning earlier about the network meta-analysis, along with the DHEA, another drug which showed beneficial result was coenzyme Q10. Similarly, even the subsequent network meta-analysis also showed beneficial result with the coenzyme Q10. However, the RCT which I mentioned earlier was the only study included in this meta-analysis. And even Peter Humaden management of POR recommends the use of coenzyme Q10 for Poseidon 3 and 4. Note that they didn't recommend it for Poseidon 2, unlike DHEA, probably because the recommendation is based on the RCT which I had mentioned earlier, which was done clearly for Poseidon 3 categories. Now coming to the comparison between coenzyme Q10 and ubiquinol. Ubiquinol is a there are some contradictory statements saying that ubiquinol is a superior molecule when compared to ubiquinone, while the fact is that ubiquinol is a highly unstable molecule, and the moment it is exposed to light or oxygen, it automatically gets converted to ubiquinone, and body actually naturally synthesizes ubiquinone and not ubiquinol. So, and the studies have shown that coenzyme Q10 is better in treating the condition and giving energy, that is ATP production, when compared to ubiquinol. So my conclusion is that as of now, with limited evidence, we can supplement coenzyme Q10 for Poseidon 3 and 4, though it is a bit pricey when compared to DHEA. However, more RCTs are required. Now coming to the next molecule, next one is growth hormone. Growth hormone receptors have been shown to be expressed in ovarian granulosa cells, theca cells, oocyte cumulus cells, mammary glands, placenta, and uterus, and it increases the IGF-1 and 2 receptors and increases the ovarian sensitivity to FSH, promote follicular maturation and follicular development. Though initial studies by Colibianchis and Cochrane review supported the use of GH, multiple meta-analysis and RCT published later provided contradicting results. Recently, a well-acclaimed multicentric double-blind placebo-controlled RCT called as LIGHT study showed that though there was a higher number of oocytes, there was no difference in the live birth rate. But then we need to be cautious about this result as the study was stopped prematurely and was underpowered. Now, this is another publication in Frontiers of Endocrinology. The highlight of this publication is that it is the first retrospective study, so first study done on Poseidon criteria. Basically, they have given it for Poseidon growth hormone to Poseidon 3 and 4 patients and found beneficial results in Poseidon 4 category. Similarly, there are many other studies and meta-analysis which showed improvement in oocyte number and embryo quality with GH, but unfortunately, it did not translate into improved live birth rate. When estradiol does not recommend it, while there may be a place for growth hormone supplementation in patients with hypothalamic or pituitary disease. Some of the issues with the GH is that it is expensive and invasive. There is no concrete supporting evidence. We should ignore the meta-analysis which compared studies published before 2011 as they were not categorized as per the Bologna or Poseidon. Many of the studies had selection bias. They were based on before and after comparisons with a lack of good control group. Even the published RCTs had ambiguity regarding the methodologies, ambiguity regarding when to start and how much to administer. Whatever said and done, consistently all studies have shown that with GH there is lesser gonadotropin requirement, earlier time to egg pickup, more oocytes and more embryos. However, no change in live birth rate. This could be probably that growth hormone may just recruit an oocyte that is poor in quality. So what is my take on that? I do not recommend it. You might question me that even many studies on DHE and coenzyme Q10 did not translate into live birth rate, though improvement in oocyte and embryo number was seen. So if I can consider those, why not GH? We need to be hyper aware that the GH is highly expensive and is an injection which need to be taken daily, ideally from the preceding cycle. We could have considered growth hormone if it was not expensive. With the current cost, now the IVF cycle with embryo pooling seems to be a logical and cost-effective option. However, there may be a place for growth hormone supplementation in patients with hypothalamic or pituitary disease undergoing ovarian stimulation. Now coming to PRP. Group from Athens had first described about ovarian rejuvenation with PRP in SRA conference in 2016, where they studied 8 postmenopausal women who had successful restoration of menstrual cycle, some even becoming pregnant or had successful oocyte retrieval. The working hypothesis behind PRP is that blood collected during centrifugation is suggested to initiate platelet degranulation process, which release growth factors and cytokines that play a key role in follicular development and maturation. There were many observational studies and few reports which showed improvement. So how do you collect the platelet concentrate? First, through a venipuncture, blood is collected, and then this is centrifuged to 1200 RPM, that is called a soft spin. And from there, the lower bottom will be the RBC cells and the upper bottom will be the platelet component. The upper component will be transferred to another tube, and again centrifugation of 3000 RPM is done, which is called as hard spin. And then the platelet-rich pellet is isolated. Actually, the platelet pellet will be at the bottom of the tube and the supernatant has to be discarded. And the platelet pellet at the bottom of the tube is used for PRP injection after activation. Some of the pitfalls with PRP is that there is no consistency among studies regarding the volume of the blood taken, what kind of coagulant has to be used, what should be the centrifugal force, and how much should be the what activating agent should be used, and the final volume, and the timing from the PRP preparation to the injection and all. Those case control studies showed improvement. Cochrane review published last month showed uncertain outcome. From Kraft, we had this oral presentation in SRA 2020 by Dr. Sankalp on the role of PRP, showing no benefit. Even the SRA 2023 recommendation is not to use PRP. Apart from that, this RCT published this month, May 2024, which was a multicentric randomized control trial, showed no significant difference in the AMH, AFC, or the outcome measures with the use of PRP. So my conclusion is that though PRP preparation is easier when compared to stem cell, there is no sufficient data to prove that it is effective, and hence its use is not recommended. Now coming to stem cells. Stem cells have the ability to rejuvenate and differentiate into specific tissues according to surrounding environment and signals. Embryonic stem cells are the most pluripotent stem cells. However, its use is unacceptable. The alternative to embryonic stem cell are the mesenchymal stem cell and the induced pluripotent stem cell. The examples of mesenchymal stem cells are from the bone marrow, fat tissue, amniotic fluid, umbilical cord, placenta. So stem cells can be injected by transvaginal ultrasound guided injection or via laparoscopy or intra-arterial catheterization of the ovarian artery. Though SRA does not recommend its use, anyone researching about ovarian stem cell would have come across this article by Sonia Herres in Fertility Sterility 2018, showing improvement in the AMH and AFC with the stem cell treatment. And in fact, some of them got pregnant also. So bone marrow derived stem cells are procured from iliac bone, and then the stem cells are isolated and they are then injected into femoral artery by intra-arterial catheterization and then reach to ovarian artery, and that is how the stem cells are placed. Now this is another Cochrane review published recently. It is actually an interim report which compared stem cell with that of GCSF mobilization, and they showed that both stem cell and GCS mobilization promoted follicular growth and raised AFC in 60% of the premature ovarian insufficient women. The limitation of that analysis is that, first of all, it is still an interim study, it's not published yet. And the second is that the study lacks a real control group without treatment, though it is difficult in case of a poor prognosis POI patients. So my conclusion on stem cell is that with current limited evidence, we can suggest stem cell treatment for Poseidon 4 and selected Poseidon 3 patients, explaining about the limitation of long-term outcome data. It is extremely important to take consent before resorting to stem cell, detailing about the possible pros and cons and complications. So the take-home message for the discussion is, for Poseidon 1 category, the strategy would be intense stimulation and synchronizing the cohort. With regard to DHEA, we can give it for hyperandrogenic Poseidon 2, 3, and 4, and coenzyme Q10 can be given for 3 and 4. There is evidence recommending it. With regard to stem cell, we can give it for Poseidon 4, but it is still in the research setting, while there is no much evidence on testosterone, GHEA, and PRP. Thank you so much for the patient listening.
Thank you, Dr. Nausheen. That was an excellent presentation on the latest update on what we can do in a patient with a poor ovarian reserve. And I think, have you got any personal experience with the stem cell treatment, Dr. Nausheen?
Yes, we've been using stem cells in some time. In fact, I think for the last 3-4 years, we've been using stem cell. I would say there's an improvement in around 30% patients. It's not that very big because we are restricting it for Poseidon 4 category only, or selective Poseidon 3 category who are affordable. And that too, after explaining that the long-term implication and all, we really don't know, because some of the patients are concerned of the risk of cancer and long-term issues with the children born in that. So we take very less number of patients, but overall, we might have done whatever we have done. The pregnancy outcome, when we have checked, it is 20% improvement in the outcome parameters from the baseline.
And how much would it cost also? How much would the cost be?
So the cost varies from the company to the third party to third party, because the third party is a company which third party people will be coming and doing the processing and preparation. Our job is to just provide the iliac bone marrow, and then they will process and give it. So the final molecule will be just around 1 to 2 ml, almost like a liquid gold. We have to inject it laparoscopically into the ovary, or for those patients who have severe additions like frozen pelvis, we can even try transvaginal. But from my personal experience, transvaginal is a very not that rewarding technique, because first of all, these POI patients, their ovaries are very, very small. And so to get into the location, this is just 1 ml or 1.5 ml. If we miss the target, we are going to waste that stem cell. So ideally, it should be done laparoscopically. But if it's not possible, we have done few cases where it was done transvaginally. In fact, one of the patients who got pregnant today, her AMH was 0.01. She had frozen pelvis, because of which we could not do a laparoscopic stem cell. She was very adamant on self-cycle. She was not keen for donor because of religious reasons. And we did vaginal stem cell. To be very honest, I was not happy with the procedure, but we got good number of eggs. But finally, we got one embryo. That to a day 3 moderate quality embryo, but conceived today. She's beta positive today. Yet to say an outcome, but beta positive today.
Congratulations on that. And how many patients have you actually done, and how many have so far had an ongoing pregnancy with stem cell?
I don't want to say any number without looking into the proper data. But from the analysis which we have done roughly 8 months back, the improvement, as I was mentioned earlier, there was 20% improvement. Whatever was the AFC, there was 20% improvement from that.
Then what is your experience with the PRP?
PRP, again, it is easier to do when compared to stem cell, but we didn't find a beneficial result. But some of the patients got pregnant. But, I think it might be just a cohort which favored the pregnancy rather than the PRP. Overall, with the whole cost involved, even to be very honest, even stem cell with the cost involved, we really have to think whether that's very cost effective, because finally the patient has to still pay for an IVF cycle. So only an affordable patient can go through it. But I don't recommend PRP.
Yeah, we also tried for some of the cases. We were not happy about the PRP.
Yes. Probably for thin endometrium, PRP is good, madam. Better than for this.
Not for PON.
Since we have some more time, we would request any of the other delegates also to put in their inputs. Dr. Leena, would you like to say anything about this topic, madam, about the second topic?
Yeah, Dr. Nausheen has covered all well.
Your experience.
Covered. We have tried GCSF in lot, but not much results in thin ET patients. PRP, we are also not happy with that. We have stopped doing it.
Yes, ma'am.
Actually, for one of our patients who many cycles failed, we tried with the tamoxifen cycle. She was nearing the perimenopausal age. Tamoxifen cycle, we added Silrate, then this transdermal estrogen seemed to work along with Placentrex. Then with a lower margin, it was only 7.5, and we had done an embryo transfer, and now actually yesterday I could see the fetal heart.
Anybody else would like to ask any questions or give their inputs? Dr. Geeta Haripriya, madam, are you here?
Geeta Haripriya, I saw her name. Yeah.
It was there in the...
Yeah, I think they have left now. So Dr. Shantirani is there to give the vote of thanks. Dr. Shantirani, she was actually in a Madurai workshop.
Okay.
Alder. Shanti, are you there?
Yes, madam. I was listening.
Yeah.
It's actually, we are having our own CME today with the Secretary General.
Okay.
Am I audible, madam?
Yeah.
Yes, ma'am.
Yes. Thank you so much. I am in the Hotel Rivera, expecting Madhuri, madam. Thank you, madam. Thank you for having this opportunity to deliver the vote of thanks. I thank the both speakers regarding this ovarian disease. Yeah, thank you so much. Thank you for all the delegates, and thank you, Ramni madam. Thank you, Victoria, for giving me the opportunity to listen to a good talk. Thank you.
Thank you, madam.
Thank you. Okay. I think we can.
We can come.
Thank you.
Thank you so much.
Thank you, Dr. Leena and Dr. Nausheen. It was excellent. Thank you.
Thanks again.